This is a totally virtual meeting, so thanks everybody for joining. It's great to see all of our panelists. It's a real honor to host this. I wanted to thank Patty and Alina from CHESA for helping organize this and take advantage of Dr. Varas visiting us from Chile here in San Francisco. And we have Dr. Akoko in Tanzania and Dr. Mbine in Uganda to speak with us, as well as Dr. Brand, one of our chief residents. So I think we can start. We have a really exciting panel on laparoscopic training and simulation training and surgery. This has been a really exciting collaboration that we've seen evolve with a number of our partners, and it's been great to kind of learn from all the work that they've done. So our panelists today are Dr. Varas, Dr. Brand, Dr. Akoko, and Dr. Mbine. And they're all going to talk to us a little bit about laparoscopic simulation in their contexts and how these programs have grown and learned from each other. I'll introduce them each as they speak, and then for anyone who's on the chat, if you could just put any questions that you have or comments in the chat, we can try to address them either individually as the speakers, after between the speakers, or at the end, we'll also have time for discussion. I'm sure a lot of the participants have been part of either laparoscopic simulation or laparoscopic surgery development in their own contexts, or surgical simulation in other settings. I can just see from the participant list, quite a few of our CHESA fellows from different countries who are on the call, and I'm sure very interested in learning from this panel to maybe even get involved in some of the work. So I'm first going to introduce Dr. Varas, who I've actually not met in person yet, but hopefully maybe during this visit. He's actually based right now at our skills lab here in San Francisco. He's visiting us from Chile, and he is an associate professor of surgery at the Pontificia, please correct me, Universidad de Católica in Chile. And he is the vice chair of simulation and experimental surgery there, and he specializes in surgical simulation, and his focus is specifically on reducing human error through enhanced training and feedback mechanisms. He spent some time with us several years ago at UCSF, and that was part of how this program grew, just through all the work that he's done in South America. So Dr. Varas, it's great to have you. Please take it away.
All right. Thank you so much, Dr. Osgedis. And thank you, everyone. For me, it's an honor to be here with our colleagues also from Tanzania, and with Nathan, who has pushed this project very far and much farther than I ever thought. So for me, it's going to be it's just an honor to talk about what we do in Católica University, and how from Católica University, and with an intensive collaboration between different universities such as UCSF and MUHAS and Makerere University. This is, I think it's going to speak by itself from the impact point of view. So I'm going to talk a little bit about how feedback may improve surgical training, which is obvious, but nobody is applying this worldwide. I don't know, especially it's because I'm going to talk about the bottlenecks to establish a training center, and how our methodology works, so that you can understand what we intend to do and spread through not only Africa, but other countries, other continents. So the first thing we need to know is a little bit about medical education, and we need to understand that, one thing is to basically know things, and another thing very different is to demonstrate that you can actually perform things. So I know this sounds very obvious, but for instance, if we want to revalidate our titles, let's say I want to come to the US to become a surgeon, I need to do mostly USMLE and the steps, and then maybe, well, I'll get approved. But that's very different, right? So to demonstrate my skills as a surgeon. So for instance, if I ask someone, hey, how do you operate an appendix? They might tell me with great detail how it's done, but this doesn't mean that you can actually do the psychomotor skill of doing. So we need to be able to address this. Why? Especially because in simulation, there's a lot of VR and a lot of scenarios that we need to understand which level is it that we are achieving. So for each level, we can do some different types of assessments. And then with simulation, the good thing about simulation, if we can establish a very good program, is we can do a buffer before we get to patients. Now, for so long, the simulation training has been confused with an introduction to the patient. So simulation in healthcare is usually basic, very basic. And then when you get to the patient, things go hard again. So I don't understand why we do this in healthcare. Now, if you go to music, they will train the most impossible pieces of music and artwork ever before a concert. And then they will perform greatly. If you ask a magician if they will, do the basic before their beautiful entertaining systems and playing in Las Vegas, I guess they will tell you no. They super train so many times, they shorten their learning curves, and then they perform in the spectacle they do. And then the same happens in all other disciplines. But when it comes to surgery, for instance, we still have the discussion of how many patients do you need to, establish a learning curve, for instance, to do a lap Whipple procedure. Oh, it's about 80. And you say, why? What? Uh, can you imagine NASA discussing this so that to understand if they're all gonna reach Mars? It's like, oh, we just need to go 60 times to Mars in order for us to really get to Mars. That doesn't happen. And the solution to this problem is to shorten the complete learning curve through simulation. So how do we train simulation? We need three pillars. This is just an easy framework for us to remember where bottlenecks usually appear when we want to do a training system. So the first pillar is the space and infrastructure. Yes, we do need a place where to put the simulators, and maybe sometimes you can train some skills at home, but we call that the first pillar. If I want to train you in guitar, uh, let's say music, you'll need to access a guitar. That's the complete concept of the first pillar. The second pillar is the training program. So, okay, what are we going to do in this guitar? What are we going to do in this simulator? How many sessions? What is the instructional design? What is the learning objective, which is the most relevant question at the beginning of any training? And if we are very serious, we hopefully we'll put some data from that training program, and we'll try to understand if these training programs transfer to the real scenario. What I mean with this is if they have predictive validity. So if I train advanced laparoscopy, then I'll be able to do advanced laparoscopy on a patient. And if not, my training program has a problem. So it's very simple, but not many people do this. I don't know why Skills Lab just put some games there and tell trainees to go and, this will work because we think it will work. But if we start measuring, hopefully we can get there. We can actually achieve results that are comparable to the things I was telling you before, like NASA and other stuff. So the third pillar is the most relevant bottleneck everywhere, and is the teaching network of instructor. Who does the feedback? Uh, we can also call this the accessibility to feedback. So if I'm a trainee and I come here to the skills lab, I need a teacher to tell me where my mistakes, how I'm doing my mistakes and how to improve them. Because most surgeons, we will carry out many unconscious mistakes that we have not even thought about them. And once a trainer tells me exactly where my mistake, I can, with effective feedback, I can then improve that behavior and thus, correct and improve my learning curve. So I'm going to show you some first pillar. This is how some first pillar work. This is just example. So you can get very advanced in laparoscopy Of course, everything that can be applied in laparoscopy can be applied in robot, and it's very simple to adapt it. I have the same box for the robot, but you can see here that you can actually suture a portal vein with ex vivo or synthetic tissues. You can perfuse with blood, fake blood, and this may help us, then think of a training program, and then design this training program so that you can actually master this type of skills that you need. Hopefully, that will never happen on a patient, but whenever it happens, you are so ready to deal with this problem. So this is just other examples of first pillars. I guess the literature has so many first pillars, like there's so many models out there. Pediatrician models, endoscopic models. This is one we designed for hernia. I wanted trainees to understand the real anatomy and to be able to dissect. This is for penetrating cardiac injury. This is just for colorectal surgery, because usually the ergonomy is the problem more than the model itself. So we use a synthetic colon, but that's just the model. We now need to understand better the training program. So I'm going to speak a little bit about the second pillar, which is actually available everywhere, including with my friends in Africa. So the training program, here you can see a gymnasium. So it's the first pillar. And I'm showing you that the training program consists of doing a lateral bowel anastomosis in a constructivist approach. So basically, you're going to keep adding new stuff to the sessions so that you repeat the basis, but then you improve while you proceed in this program. The training program lasts 16 sessions, so it's very different from so many other programs out there. Usually training programs, before we established this advanced program in 2010, were all about 2 days of training. Usually they were right next to a meeting, like a surgical meeting. So you go to a surgical meeting and you do a 1-day intensive course, or you can go to EARCAT and maybe do a 5-day intensive course, or you can go anywhere, but usually it's not more than 2 or 3 days course. And if you can see here, the training program is important that first of all, you can flatten the learning curve so you know how it behaves. This is 25 residents who were interns back then. And you can see that the group is pretty heterogeneous at the beginning and end up very homogeneous and of a very high quality at the end of the training. Actually, the worst performance at the end of the training is much better than the most talented person at the beginning of the training. So for minimum competency, this is great, right? Imagine, well, Patty sends me all of her residents, and then I deliver the residents after a month in this level. She'll tell me, oh my God, they're so talented. But in the end, it's just practice. And that's the whole message here. You need to practice, have good quality practice instead of just talent. Before and everywhere, this person would have taken so many invitations to do all the surgeries because she or he would be the most favorite surgeon resident just because the person is talented. But this doesn't mean actually that anything. You just need to train them. But this is how this behaves in the skills lab. What if I tell you that, for instance, do you know PlayStation? So imagine if you're playing soccer in PlayStation. There's a very good game called FIFA PlayStation. Of course, you have the NBA PlayStation, but imagine you're playing FIFA PlayStation, and I'll tell you, hey, now that the trainees finished the training, they are all good at soccer. You would tell me, no, I don't believe this. Because it's different, right? So as a chair of simulation at Católica, I need to question the programs. One thing is to see these beautiful numbers, and another thing is to understand if it behaves good in the operating theater. So what we did next was to take these junior trainees. We wanted to compare them to general surgeons graduated from traditional programs, but without simulation. So basically, junior trainees who just finished the program, the advanced program, and we then wanted to compare them to 5-year general surgery residents recently graduated from a 5-year program, but without simulation. And you can see that the worst performance of a junior trainee with this advanced program doing an advanced case, this was a Roux-en-Y gastric bypass on a patient supervised by experts. What is much, much better. The worst performance is much better than 5 years of general surgery training. So, so I think from a cost-effective point of view, we can start making some decisions. For instance, to include a 16-session training program in a 5-year program, come on, sounds pretty reasonable. And what I don't know why is why we are still allowing our trainees to go through the natural traditional learning curve and not through this intensive, very good complement learning curve through simulation. Now, who is doing the teaching? So who is doing the third pillar? And this was very important. At first, I wanted my experts to go to the skills lab. So I called all of our experts to just reach the skills lab whenever our trainees were ready. And our trainees were ready on Monday, Tuesday, Wednesday, Thursday, and Friday. So they're always eager to learn. The problem is that my teachers are not always available. So I realized that I had a very huge bottleneck if I wanted my experts to go to the skills lab and provide good feedback. They were never available. So if you see the analogy here in soccer, this is the Paris Saint-Germain, the kids of under 12. And who is training these kids is this person that nobody knows his name. He's not famous. He's not even a soccer player. He actually is in this case, he's a physical therapist that learned how to train this specific stage of life of these trainees. And he knows exactly what to tell them. He knows exactly what feedback is the one that is going to put them there in the next stage, which maybe is under 15. And then the guy that comes after will teach them specifically what to do under 15 until they reach professional level. Maybe at the professional level, this guy has no clue of what to say. He just knows the stage of these kids. The analogy is very good because we need to professionalize teaching, especially if we have validated courses at simulation. You can have professional people that can provide very good feedback if they know the course. And what I did at Católica was to start training veterinarians, to start training general practitioners, and they became really good at providing feedback in the advanced program. And the learning curve I showed you was achieved with these teachers and not with expert laparoscopists. Now, expert laparoscopists doesn't mean they are good at teaching. So you can be good at, maybe you're the best at doing an intracorporeal suturing, but this doesn't mean you know how to teach intracorporeal suturing. And this is a paradigm that we need to learn. We need to learn that to become a teacher, you need to also do a learning curve for teaching, and you need to practice how to provide feedback, effective feedback. So what happened next was something very interesting. People from Peru, Bolivia, and all surroundings of Chile wanted to obtain this course that we created at Católica because, as I'm telling you, with 16 sessions, it's like almost 5 years of general surgery, at least from a skills level. So imagine the word of mouth was really strong, and everyone wanted to go to the skills lab to train. And they started flying to Santiago, staying for a month, paying a hotel, paying for the trip, and also paying for the continuous medical education course of the advanced program. So it was very expensive. And everyone started asking me if we could train them at home instead of, and maybe locally in Peru, locally in Bolivia, locally in Brazil. So is it feasible to train someone with this program at a distance? And we created this platform, and in honor to William Halstead, we call it See One, Do One, Teach One. Teach One is actually our AI, but we shorten it to because I like Star Wars, so that's why it's written like See One, Do One. But basically, in order to William Halstead, who always said See One, Do One, Teach One. And I'm gonna show you how the course I showed you before in person, now how it works remotely and asynchronously. So you download the app and you'll see tutorial videos. And these tutorial videos will show you how to prepare the bowel, how to, put yourself in front of the simulator, how to do suturing, how to basically, do everything so that you don't have any kind of questions, so that you cannot ask us through WhatsApp or anything. The idea is that you can self-train if you have all of these tutorials. Once you have seen your first session tutorial, then as a trainee, you go to a skills lab who will have the first pillar. They need to have the first pillar. If not, they're not going to be able to train. So then they'll just record their first session, and this session is going to be uploaded to the C1 Do One cloud. And what is it, the cloud? This is the vision we have. I asked Nathan to provide permission for me to show this video. So this is actually Nathan training his fifth session. And you can see that I can see all the details here. I can put some, all of the type of rating scales I can use. All that's, you can add any type of rating scales. You can measure time, but then you can draw in the screen. You can tell an audio memo. You can see that I use a lot of audio memos. So all of these points, dots here in the timeline are specific interventions where I detected there's a mistake, and how to improve that mistake is explained by my audio memo or a drawing, or even emoticons. Like here, I was a bad teacher with Nathan. Yeah, sorry for that. But then you can see that Nathan receives this in his own cell phone, and he can go straight to the feedback points and understand where he failed and how to improve that mistake. So it works, but asynchronously. I have usually, as a teacher, 72 hours to address that there's a pending assessment, and I have 72 hours to basically do the assessment. Then we put science on this, and we started understanding if it compares to the in-person feedback, which is the control group here. These are people trained at Católica University, and this is people trained remotely and asynchronously in the north and south of Chile. You can see that both groups improved really great. So once we realized this, we were understanding that we were able to train someone at a distance, and with something such as the advanced laparoscopic program. So we started expanding to different countries, and that's how we went to Peru. This was prior the pandemic, to Bolivia, to El Salvador, to many, many countries. With the help of a SAGES grant, we started expanding, and we realized impressive things, such as with 8 instructors, I was able to train over 300 trainees a year, which from a scalable point of view is amazing, is very great. The one center in the US is actually UCSF. And that's how I met Nathan, who was there eager to learn advanced laparoscopy. So we started talking, and he had this great idea of expanding to Tanzania, but he will tell you more about this. Thank you for your attention. And this is basically what I wanted to show you, is how the system works, so that you can now imagine the crazy things that Nathan did locally over there. And we hope to hear also our colleagues from there.
Thanks, Dr. Varas. That was amazing. And I'm going to quickly move on to Nathan. Dr. Brand, our Chief Resident in General Surgery, who is also a CHESA Fellow and an NIH Fogarty Fellow, and lived in Dar es Salaam and built a lot of close relationships with surgical faculty and trainees there under the mentorship of Dr. Akoko, who we'll also hear from next. But Nathan, please take it away. You're muted.
Thank you. As Dr. Varas kind of pointed out, when I was at UCSF, I was able to be introduced to this incredible training program, and you could see all of the science behind it and this amazing curriculum. So I was going to be traveling and spending a year with Dr. Akoko in Tanzania, and we were very excited to see how we could adapt this program first to Tanzania and then further on expansion into Uganda. And kind of the need for us that we saw was that when you look around, while there are multiple barriers to laparoscopic surgery, we're not trying to say that all we need is training. If you look around the country, at least in Tanzania, at some of the bigger referral hospitals, laparoscopic equipment is available at many of these hospitals. However, despite them being available, less than 5 laparoscopic cases were being done at 90% of these hospitals, showing that there's a huge opportunity to expand the amount of laparoscopic surgery happening. And because of that, as you know, 80% of the time, this equipment is sitting idle. And we saw training and simulation as a significant barrier to be able to create the expertise in laparoscopic surgery to be able to expand the amount of minimally invasive surgery happening in the country. Next slide. So, and as everybody knows who's a surgeon on this call or works in perioperative medicine, increasing rates of laparoscopic surgery has the potential to significantly improve surgical outcomes. That's why minimally invasive surgery is now the standard of care for appendectomy, cholecystectomy, and many other operations in the US. And the reason for this is that there are, you know, shorter hospital length of stay, fewer complications, and improved quality of life. And while this has been proved in high-income countries, there's no reason to expect that it would be dramatically different in a place like Tanzania. Next slide. And we did a little bit of this work kind of on a prospective study that we were doing at Muhimbili. And what we found was that patients undergoing open laparotomy at Muhimbili, only 11% of them were able to return to work a month after their discharge. And if you look in the literature, you can find programs such as this program that has significantly improved the amount of laparoscopic cholecystectomies that happen in Mongolia and other low-income countries. And what they found is 75% of their patients, after undergoing a laparoscopic cholecystectomy, were able to return to work a month after surgery. So just kind of showing the need to expand laparoscopic surgery in low middle income countries to be able to allow patients to return to work faster and make up for some of that lost income they may incur. Next slide. So with this in mind, we launched a partnership and a really exciting kind of collaboration between, you know, what is it, 3 continents, 4 different institutions. So between Dr. Varas at Católica University, myself and Dr. El-Saidi and Dr. Sayed at UCSF, Dr. Akoko at Muhimbili University, and Dr. Mbine at Makerere University. And the idea was to try to bring and create high quality laparoscopic training simulation centers in Tanzania and in Uganda. And I think that there is a lot of different kind of projects out there that you can find in the literature that Julian kind of spoke to that have the first pillar of surgical training, which is a simulation center. But many of them, if you look at the details of what these simulation centers include, you'd find that these simulation centers were not using the same high quality equipment that they were using for their own trainees in high income countries. So what we wanted to do was not develop a low quality simulation center and adapt it to Tanzania. We wanted to take the exact same high quality center that we were using to train our residents at UCSF and bring that to Tanzania to be able to train residents there. Next slide. So using the LAPP program that Dr. Varas alluded to, we were able to create 2 different simulation centers. We started with a simulation center in Dar es Salaam, Tanzania, and then after 2 years of running that program in Dar es Salaam, we have expanded to Kampala, Uganda, where we're running a second center. So our approach to creating a surgical simulation center is based on those 3 pillars that Dr. Varas alluded to. But I think that some other details that hopefully Akoko and Mbine will also touch on, we really realized that one of the major things that led to our success is training and hiring a lab manager that can both run the lab and provide the feedback. Because as all the surgeons on this call know, you're already pulled in a million different directions, and expecting all of the training to fall on you in order to make these programs happen will just lead to a bottleneck and delays that will eventually lead to the lab shutting down. So we needed to train someone who didn't necessarily even have medical training to be able to provide the feedback and teach laparoscopic surgery, so that people like Dr. Akoko could run the simulation lab at a higher level, make sure that it was accomplishing the goals that are needed, but wasn't necessarily responsible for the day-to-day provision of feedback, given all of his other responsibilities. We also found it very successful to ensure that the location of the lab was in a convenient place and that it was open during the hours that trainees were being able to access the lab. As you know, surgical residents are not necessarily always available 9 to 5. So there had to be opportunities to train in the evenings and on the weekends. And we also really wanted to have ownership of the space. So when we were looking for a space, we chose a space that was smaller and less nice, but a space that we could have 100% ownership of, so that we could make sure that it was safe and open when we needed it to be open. And then we found a lot of success, and they'll talk about this, of integrating these programs into existing surgical training structures. So our program is now integrated into the residency program at Muhimbili, and is on its way to being integrated into the residency program at Makerere. So just to highlight the Tanzania lab, since starting in 2022, we've trained over 40 people who have registered. We've logged over 1,400 hours of individual training. We hired and trained a lab manager. We've, I think you can keep clicking. The lab was integrated into the surgical residency. We've provided over 3,000 individual pieces of feedback, won an ASC Platinum Award, and published a paper kind of describing these successes these successes in our experience opening this lab in Tanzania. Next slide. So now, real quick, Dr. Asgidis will introduce Dr. Akoko, and then Dr. Akoko can speak a little bit more about our experience in Tanzania specifically.
Thank you, Nathan. And it's a pleasure to introduce Dr. Akoko, who is Associate Professor of Surgery at MUHAS. He's a consultant surgical oncologist at Muhimbili National Hospital and the president of the country's surgical association. And he is actually the first fellowship-trained surgical oncologist in Tanzania. And he co-founded this lab with Dr. Brand and in collaboration with Dr. Varas. And he's going to talk a little bit about that experience. And Dr. Akoko is also in the leadership of CHESA. Dr. Akoko, please, the floor is yours.
Dr. Akoko is just texting. He's having a little bit of connectivity problems. Maybe we can move on to Uganda.
I'm back.
Akoko, are you back?
Back. I see.
Perfect.
I don't know what happened.
That's okay. No problem. We can hear
The
you.
floor is yours.
Okay. Thank you, everybody. And thank you very much, Nathan. I think without Nathan, we would not have met this nice program from University Católica. Do I get my screen?
Barris can move the slides for you.
Yeah, I can't see them.
Can you see them, Dr. Akoko?
No, I can only see Julian Veras has started screen sharing,
Okay.
but I'm not seeing.
Prof, maybe you can, if you're using a mobile phone, can you swipe left?
No, I'm on Mac.
Let me check.
If Mbimi can go ahead, and then I can come later.
Sure.
Okay. Do you want to go ahead with, I can see Dr. Faraz's screen. Dr. Akoko, are you able to see Dr. Varas' screen or have a place where you can click for his screen?
But it's just written Veras has started screen sharing.
Oh,
Maybe it's just
Yes, it's not, maybe it's because of
Okay.
bandwidth.
Could be bandwidth. Yeah. Okay.
No,
Maybe.
I just want to log out and sign in again. So to
Okay.
give me a side to go. Yeah.
Okay. All right. Then we'll go ahead with Dr. Mbine since he's on the call. It's great to have Dr. Mbine on the call. He is a general surgeon in Uganda. He's a senior lecturer at Makerere University, and he specializes in GI surgery, endoscopy, and minimally invasive procedures. And he's also on the National Executive Council of the Association of Surgeons of Uganda. He is has a very busy surgical practice and is a real champion of trying to teach MIS and endoscopy to trainees anywhere and everywhere. So he was very excited about this. Maybe Dr. Mbine, please share your perspective.
Thanks so much, Professor Doruk, for that wonderful introduction. And thanks to the organizing team, both CHESA and the team organizing the Grand Round, as well as the other panelists. It's been a great pleasure being invited and sharing our experience with you. All right, so next slide, please. So I'll just give you a bit of a background of what Uganda is and the kind of surgical practice in Uganda. We have about 48 million Ugandans. The median age is about 17, and 30% of them live within the urban areas. And one study done showed that the surgical burden of disease, the unmet need was about 3.68 million Ugandans. And if you look at the surgeon to patient ratio, is about 100 to 100,000. So you're already seeing that we have a bit of challenges in providing for surgical care. Next slide. So the evolving surgical practice in Uganda. So if you can look at the image below, about probably 60% of the operating theaters in Uganda look like that image that you see. And our dream and desire is to deliberately transform all these theaters to look like the theater that you see above. That's at the National Hospital where I work. And so with the Association of Surgeons of Uganda, as well as other key players, our dream is really to see how we can improve equipping of most of these theaters so that we are in position to provide advanced surgery, including laparoscopy. Next slide. So in Uganda, we have 5 universities providing training surgeons. We have the College of Surgeons of East Central and Southern Africa. But what's really characteristic, which is similar to what Nathan had mentioned, is there has not been a deliberate training structure for laparoscopic surgery. So most of the curricula running in all our surgical programs are actually based on the traditional open surgery. Yeah. Next slide. And at Makerere, we had a simulation lab prior to our collaboration, which had quite a number of challenges. And I'm so happy that this collaboration has brought structural sort of programs that sustain the ability of the laboratory to work. We have operating theaters in laparoscopy. And for us, I could say we took it on from the clinical aspect. So we taught laparoscopy almost right from the clinical aspect, like the traditional general surgery that Professor Veres was talking about. And of course, it presented a lot of challenges for us. Next slide. And then, of course, I mentioned the limited simulation training. You can see in that image the kind of traditional laparoscopy training that takes place. So here we have residents who are observing, a few other students as well. And without simulation training, these guys are supposed to, in one way or another, start learning surgery, right away. So this is the kind of situation that we had previously. Of course, in other hospitals, we've had issues with limited equipment. The curricula for training laparoscopic surgery has been lacking. And then, of course, the lack of strategic vision for developing laparoscopic surgery in Uganda. Next slide. So along the way, we meet with our great mentor that you see right there, Professor Doruk. Professor, do you remember that day?
Yes, I do remember
Yeah.
we get to play with some toys. Yes.
Yeah, so I set up that simulation at my private facility where Professor visited, and we were trying to see really how to meet the need, at a very small scale that Professor Varas, a kind of story that he shared. So I was actually doing training of a few residents, but we lacked structure, we lacked strategy, and we really lacked, if I might say, the strategic direction of how to scale this up. And through our interactions, Professor has always been a visitor in Uganda, and he's really done quite a lot of work in pediatric surgery, trauma, and quite a number of things. And through our interactions, the idea of, scaling up and taking advantage of the opportunities in University Catholica, came up. Next slide. And then I would say I get to meet these wonderful people right there. You can see Nathan. You can see how happy we were. And then there's Professor Akoko. So for me, this photo speaks so much because this meeting is, this moment growing and, and taking shape. So we had quite a number of fairly very good discussion on what transpired in Uganda. And I'm so happy that after those discussions, a lot of work has happened. Next slide. So I got the opportunity to pilot at the lab in Muhimbili. Right there, you can see Dr. Isabella. I don't know if she's on the call or maybe not. She actually took me through some of the, and I can tell you it was not a very easy training. It got me off guard. Nathan, you remember that? But I was greatly inspired because I was invited for a week and I spent 90% of the time in the lab. And, they would tell me, why don't you go and check out the beach? And for me, this was it. I had to find a way of passing this test, and the inspiration was great. And I'm so happy that we had to carry this on to Uganda. Next slide. And of course, Professor Akoko was a very nice and wonderful person. I don't know if Professor is back on. I have a date to Professor. Professor, we enjoyed that meet.
Yeah, I'm here.
Yes. And to tell you the truth, it would lighten up the tense moments that we had in the lab. And for sure, we were so happy that we socialized after, such busy days. Next slide. And of course, after that meeting and the discussions that we had with Professor Akoko, Nathan, Professor Doruk, it became very clear that we needed to have a strategic vision, for laparoscopic surgery at Makerere. And we shouldn't just train, because previously we were practicing, no plan, no vision. And, we've started now deliberately working on a vision of implementing minimal access surgery here. And not just to our trainees, but we are scaling it to the surgeons that are already in practice. And already we are seeing some fruit of that. Next slide. So this is our lab in Mulago. Professor Akoko, it's slightly bigger than yours.
I can see.
Yes, so yeah, so but we started with 2 stations as a pilot, and we are hoping that gradually we should have to fill up this whole place. Of course, the photo was taken in dim light, but it's fairly bright and clear. Next slide. This time we had Wibo. I saw him on the call. Wibo is the lab manager in Muhimbili, and Anthony is the lab manager in Uganda. And this was a time when we were setting up. So he really was very helpful. We set up, piloted the training. And then on the right, Dr. Treasure, I'm told he's been the best performing, in Uganda, he was the best performing surgeon. He was our first candidate. He trained well, he excelled, and we thought everyone was going to excel like he did. But I think that's something we are going to discuss. Our graduation numbers are still a bit low. I think it's less than 25%, and maybe as we discuss, we need to see how to improve them. Next. Some of our residents, they are doing the training. They really love it. They enjoy themselves. Anthony always tells me he has to chase them out of the lab. And maybe that's another thing that we have to think about as we improve our program. Next slide. Yes, so currently we've had 17 participants. 3 have completed the course. There's been a lot of interest at Makerere. All the residents have signed up. We can't take them up, so we have to strategize on how to take them on. We have universities outside Makerere that are also very interested, and we actually also have surgeons that have actually shown interest to enroll. Next slide. Maybe before just the back, one step back, the previous slide. So you can see the surgeon, this is a fellow practicing, and then in the next slide, she's the same fellow I'm working with during the surgery. So I've had a very interesting experience with the fellow that I'm working with. I saw it's almost, I don't know how to describe it, a transformative sort of experience before and after enrolling. She's supposed to sit her exam probably next week. So prior to the training, she used to make my life very difficult. I was always almost shouting at her. So she enrolls, I sent her to enroll for this course. She enrolled. And lately, she's actually, I'm almost handing over the surgery to her. She does most of, I do the difficult parts, she does the other parts. And you can really see the immense transformation that this training program has had to. This is a single fellow that I've closely worked with. Next slide. Oh, before that. So now the key issues, we are working on integrating this training into our curriculum at Makerere. All the fundamentals have been done, and I can say that we are very sure that once the new curriculum is out, which is probably this year, we'll have this program as the main simulation program that our students will take on. We've piloted it, we are very happy with it, and of course, we are still working around how to get our graduation volumes up. Of course, you saw that we have 2 stations, and now we're having a waiting line of interested participants. So we also need to think of how to scale up the stations. Of course, those who are graduating, they're also asking us, what next? Are we ready to operate? And then we have to strategize on how do we handle, how would we provide a wet lab, a cadaveric course. And then Professor Doruk, I think we discussed this. Can we integrate, how can we create a clinical fellowship such that these residents can seamlessly join a fellowship program so that at the end of their program, we can say we are graduating competent laparoscopic surgeons. And of course, the collaborations, we are hoping to see how to, next slide, please, to work on these collaborations. One time I was having a discussion with Professor Akoko when I was in Tanzania. How do we get Makerere residents to go to Muhimbili and learn from his expertise? And how do we get some of the residents there to come to Makerere and benefit from the expertise in Makerere? Because there's no one single institution that is exceptional. So we are looking at that. We are looking at faculty and examiner exchanges. And then of course, is there a way we can integrate such a collaboration and the exchanges into formal training so that our students can get to have an opportunity to experience the other centers. In that photo, you see Kara and then Wibo. So Wibo is from Muhimbili, Kara is of course from UCSF, and they are in Uganda. So there's no better photo that can show collaboration and the spirit of collaboration than this photo. I think my last slide, if I'm not mistaken. Okay, so I had a nice evening with Wibo. You can see the beautiful Kampala sky. Unfortunately for Wibo, I just had the sky to show him in Kampala. He was here for 2 days. But when I was in Tanzania, I had the opportunity to see one of the most beautiful places. You can see me there with Isabella at the center of the Indian Ocean. Thank you so much.
Thank you, Dr. Mbine. That was great. Wonderful. Highlighting the collaborations, which are really the heart of this. I'll see if Dr. Akoko, can you hear us?
I can hear and I can see everything.
Okay, wonderful. Please go ahead.
Yeah, so thank you. I don't think I'm going to go through the slides. Most of the things have been covered by the previous presenters, but I just want to address that we have in our curriculum, because our curriculum. Yeah, I will not be following the slides. I don't know that introduction. So our curriculum is written and there is no space for laparoscopy, but we had that move and desire to want our residents to go through laparoscopy. Of course, we have written a new curriculum and the proper laparoscopy and skills training simulation, both open and laparoscopy. But in spite of that, we have piloted the feasibility of having residents go through a formal laparoscopy training program at Muhimbili. And to achieve that, we have made the lab open 5 days a week, including extra. Sometimes they push Weibo. They have made personal friendships in the open lab, sometimes up to late at night, and sometimes over the weekends. And we have remained with a strong desire to ensure that laparoscopic equipments are available where our graduates go when they graduate. And one of the problems with the laparoscopy is the expense. I think the first commercially available laparoscopes in Tanzania were Calstros, and they were expensive. And now there are cheaper versions of laparoscopy. And we are moving forward to have regional hospitals have laparoscopy as we are finalizing our study to prove locally that laparoscopy actually has more benefits than open surgery. So we just met a company that's assembling laparoscopic towers and selling a complete tower at 39 million Tanzanian shillings, down from 300 million that Carl Stores was selling. And we're meeting with the medical stores department that procures for public facilities, and they are very enthusiastic to ensure that all regional hospitals have laparoscopic equipment. I think this was the biggest obstacle to laparoscopic surgery in Tanzania, lack of towers and lack of formal training, because even at MNH where we have tower, only 4 or 5 surgeons have been doing laparoscopy on restricted days. So that means on the same room with laparoscopy, a lot of open surgeries will be going on surgeries that can be done laparoscopically with a lot of negative laparotomy rates with its long-term complications, including delay in returning back to work. So even our students who are doing Master of Science in GI surgery were having difficulties getting laparoscopic training. It was not in their program that it was mandatory to have a simulated training. So I think we'll need to, as Mbime said, we need to find ways of collaborating cross-border. It's easy to collaborate in US, but I don't know why it is difficult to collaborate regionally. I think the money to move us around is always a challenge. And of course, if we can mobilize resources, it would be cheaper to do cross-border within East Africa regional movement than to fly to US. So I think those are the things that we need to look at in the future, whether we can jointly develop a program to certify now properly trained laparoscopic surgeon to do the advanced ends of laparoscopy like rectal surgery, Whipples, and more of those. But for cholecystectomy, diagnostics, appendectomy, I think our lab has demonstrated that it can achieve that. All the surgeons that we have trained in our lab and have gone to centers that have laparoscopic tower have been able to do laparoscopic cholecystectomy, appendectomy, and they are eager to advance more. So one of the other challenges was having carbon dioxide delivered across the centers, and this has been a problem. And an Indian venture is selling a gasless retractor at just $800. So that has even pushed us harder to convince the Ministry of Health that we can actually do laparoscopic surgery, even in the very remote centers. With the 39 million tower, I believe that even the general doctors will be able to put a scope and see whether surgery is needed at the district hospital. I think the biggest obstacle will remain in the instruments. Instruments prices have not come down yet. I think there are still very few manufacturers of laparoscopic instruments, but I hope that if we join hands in global efforts together, we'll be able to bring down the total cost of both the equipment and instruments and be able to deliver minimal invasive surgery to the millions of people who need them within the region. So I visited Rwanda and I found them having the most fancy minimal access surgery. I think even sophisticated than the one you have at UCSF. And it was very expensive, and that's what the College of Surgeons East Africa is trying to promote people to go to. And I told them very cheap one that can take you straight to the operating room. Because if you only have games, the high-end movements will not make you a laparoscopic surgeon. But with bowel surgeries and advanced components that we have in our very low simulator model, I convinced them that we can have this. I think one of the things that we'll need in the future is to find a way of having sustainability plans beyond the thing. And Weibo has been very instrumental in assisting us in this. I think one of the problems we have had before is who should be the lab manager? Should it be a surgeon? Should it be a medical doctor? And seeing the type of troubleshooting that Weibo was able to do for us in this lab, communicating sometimes with Chile. Sometimes he just said, no, it's just a USB port. I'm going to work on it alone. We would not have been able to do that. Without him, now we would be requesting for new models. Yeah, so thank you very much, Weibo. And thank you very much, Julian, for having introduced this concept that somebody doesn't need to be a doctor, leave alone to be a surgeon, to be able to assist the trainees in their initial training, and we take over when they are now moving to advanced training. Thank you very much.
Thanks, Dr. Akoko,
Back
for
to you,
those
Doruk.
insights. Thank you so much for those insights, Dr. Akoko. And I wanted to thank all the panelists. We can go a few minutes over or past the hour, but I really wanted to thank all the panelists. I think this is a program that we're really proud as CHESA to be supporting. It's been incredible to see, and Dr. Varas, really all your groundbreaking work in South America, sustainably getting skills out to all the countries, homegrown, and then expanding this in East Africa, learning from the Tanzanian experience and the Ugandan experience. And I think from CHESA side and all of global surgery should really be around these types of collaborations and learning from each other. There were some questions in the chat, and I'll just point out in the chat and the participants, we have colleagues from Jordan, from Ethiopia, from Nigeria, from Somaliland, from Nepal, from Mozambique. We also have colleagues from many different specialties, including anesthesia and other surgical subspecialties, all of whom are doing simulation and can learn from these models. But there's some questions in the chat. Maybe one question again is maybe on just the clarification of exactly how feedback happens in the model. And so I don't know if one of the panelists could address that.
Maybe from a technical point of view, I can reply that. Basically, so we need a video recording of the simulation session, and then it's uploaded to a cloud. We don't need that high quality video. We've demonstrated that with low quality video, you can actually, if in the other side, you'll have an expert surgeon, you'll be able to assess this very good. There's two programs. One is the basic curriculum and then the advanced curriculum. Actually, we have 16 other programs, and we're hopefully going to incorporate them as soon as possible in Tanzania, and why not Uganda. The feedback happens that we've developed a system so that we can keep track of the sessions, develop learning curves, and you not only see the performance of the trainee, but also the performance of the trainer. So we know exactly if quality feedback is happening. And there's also, as Dr. Akoko said, train the trainers course and a train the administrator course, which are fundamental to establish a training center. You need to train first the administrator so that they'll know how to schedule the trainees, how to prepare the bowel, how to prepare the simulator, and everything else. And then we need to train the teachers, right? And in this case, when we trained Weibo, who has been a formidable teacher, he first did the course and then was trained with the trainers. He received feedback, so he knows how to then empathize with the system. So that's how it works.
Thanks, Dr. Varas. That's great. And then there's a question about expanding to Ethiopia. Dr. Mekdim from Ethiopia, one of the surgeons who's in the CHESA Fellowship, was asking how, if there is interest in other countries in the region, how can we go about that?
Yeah, I think there's a lot of interest in expanding to other countries. I think that as Dr. Akoko was kind of mentioning with the regional travel and building regional expertise, we have a strong interest in kind of creating regional expertise in East Africa, where trainers in East Africa can be supported by one another rather than it being specifically a north-south relationship. So we're really excited about it. As you can tell, there's a fair amount that goes of kind of human capacity that goes into creating these labs, because each time we have a lab, we find a lab manager and train them, requiring them both to take the course as well as take the teacher training course, so that they have the expertise necessary to provide the feedback. So I would kind of, the reality is at this point, our major expansion bottleneck is just in fundraising and funds, because we don't want to start another lab with at least 2-year runway of being able to pay that lab manager, because if we're expecting a lab manager to dedicate themselves to create this expertise that wouldn't necessarily be easily kind of put into something else, we want to make sure that we can guarantee that they have a job for at least a couple of years to make this happen. But with more funds, we are very excited to expand.
That's something that I think we can all work towards. And then there was a question, Dr. Mbine, for just expanding to other programs in Uganda. And I think we talked about this when I was there a few weeks ago. Could their residents come and maybe train in the skills lab in Kampala, which I think is very feasible. But what are your thoughts on that?
Yes, so right now we've had some trainees from Uganda Matters University, that's the other university in Zambia. And we are really looking at how do we integrate. Right now, everyone is open. Anyone can come in from any place in the country. But we are mindful of also pediatric surgery. You know, we talked about Makerere University. So we need to work out really how to get everyone on board. But also maybe later on, once the program is established, maybe we can see if it's feasible to create satellite training programs within Uganda. Thank you.
Or it might be possible to, if they are able to get clearance from their program, to be, say, in the lab for a week, kind of continuously doing modules, or even longer. I wonder whether that concentrated, skills time might be something that could be considered. So
I agree, because the trainer from the other university had to trek about 15 kilometers, and of course you can imagine, and this is a high level course, you really need you to be in the best, you give it the best of your time. So definitely it's something that we look forward to carrying on forward.
Well, we're at about 7 minutes over. Any last final burning questions from any of the people on the call for the panelists? Okay, well, we've recorded this. We'll definitely send out a recording for those that couldn't join, because I know there are probably people in our community that would love to see this, so we can share it, and we'll share it with the panelists. And I really appreciate everyone for joining, and wanted to really thank our panelists for an amazing presentation. I know it's late at night in East Africa, so appreciate you joining at that time zone. But congratulations on all this work, and we really look forward to continuing it to grow it with everybody. across the region, hopefully across the world, and across other areas of simulation and other surgical specialties in anesthesia. So great to see everybody, and have a great day.
Have a great day.
Thank
Thank you
you.
for the